So I mentioned before the iris registration. I think this is a really cool feature, specifically in the LensR, but a lot of them have something like this now. It's a specific anatomical landmark that we're looking for. So, I mean, Priya, when you do a toric lens in the traditional the old-fashioned method, how do you line it up? How do you line your axis up with patients pre-op?
Yeah, it almost feels like you're shooting in the dark, but
Yeah.
I can use one of the robo markers and kind of try to mark at 0 and 180 before the patient lays down. And like you said, there will be some cyclotorsion. Once the patient lays down, then you can kind of precisely, you can use a Mendez marker or something and decide exactly where that toric lens should go. But it certainly feels far less precise compared to having actual marks on the cornea and the capsulorhexis.
Yeah, I mean, I feel like if you're within 5 or even 10 degrees, that's pretty darn good. But
Yeah.
that is a significant miss. I mean, if you're 5 degrees off with a high toric lens, that's a problem, and that can be a problem. And so
Yes.
with what the laser does is it actually focuses on a specific crypt in the iris that we're gathering preoperatively in our clinic, and then we can use that and then line up with that where the axis should be. So it becomes way more high tech, way more accurate naturally. But it takes it from our pentacam from our in our clinic and our pentacam, and we do that. So about 1 degree off, just a real rough estimate. If you're off by a degree, it equals about 3 1/3% of reduction in your cylinder power. So if you extrapolate that, if you're off by 5 degrees, you're off by 17% of your cylindrical power. 17% of a, oh, my dog's joining me. Say hi to Oakley.
Mhm.
Um,
Yeah.
if you hey buddy, if you're off by 17% in a high cylinder case, that's going to be a problem. So again, going back to optometry contact lenses, we got this thing called the Lars rule. So if you got a contact lens that's sitting a little bit off axis, left add, right subtraction. This is our way to compensate. And we do that by just taking the lens off, putting a new lens on. It's very easy. We've got whole trays of them in the clinic. We don't have the luxury of doing that in cataract surgery. So you really do have to get it right, especially those high SIL cases. So this just shows again kind of what the iris recognition software does for us. More than 50% of patients having cataract surgery have corneal astigmatism over a half diopter, but cyclorotation is also very common. So this study shows exactly how much cyclorotation we can expect. The mean absolute value of cyclorotation was 5.81 with a standard deviation of 4.2, ranging 0 to 17 degrees. So again, think 1 degree is about 3% off your cylindrical power. If you're off 17 degrees, I don't know, quick math, that's a lot. It's a big number.
Mhm.
And so we really want to make sure that we're nailing it. So not only is it giving us the access, but it's dialing these little kind of nubs in, and it just makes it so much more easy. I mean, Priya, you can attest, so much more easier to line that lens up. But for me handling the post-op, I can now see where the lens is supposed to be. So if I have a patient who is not seeing as well as I would expect, or they've got kind of a wonky mixed astigmatism prescription after, and they shouldn't, I don't have to rely so much on where I think the lens should be placed based on pre-op scans. That's how we did it before we had the laser. I would look at their topography pre-op, see where it was supposed to be, and kind of use that as my guide. But their astigmatism can change from surgically induced astigmatism, and that can shift where the axis is, and it shifts where the lens should be. So this allows us to really see with in real time where that lens should be sitting, and we can use that to troubleshoot if we need to. So advantages of iris registration. We're utilizing the axis, the capsular marks to allow precise IOL centration, increasing confidence, obviously, increasing patient satisfaction. Now, again, you mentioned the higher order aberrations. These lenses do rely on elements of higher order aberrations. So if we've got a multifocal or an EDOF IOL, now we throw in an astigmatism component to that. That lens has to be not only no tip, no tilt, but it's got to be oriented properly. So there's so many variables that we've got to take into account. Priya, why don't you talk to us a little bit about the AKs and kind of how that works?
Sure. So as you were saying, these AKs are crucial for torics will start maybe depending on whether it's with the rule or against the rule astigmatism, it may start anywhere from zero 0.8 to 1.3 diopters. So what do we do for everything less? Because we know that a lot of our, especially diffractive lens optics, we need to be as precise as possible because even half a diopter of astigmatism can make a difference, not only in their visual acuity, but also in their dysphotopsias. So LRIs, this kind of shows where the optical zone is and how deep we're going. So LRIs, you can see is 90% depth. And then intrastomal astigmatic keratotomy, so AKs, you can see goes deep there as well. And that's going to be, it's very important for it to be outside of the optical zone. So I can tell you as a corneal specialist, sometimes if you place it a little bit too close to the center, that can cause ectasia, and I have seen that. So that is important for it to be sufficiently far away from the corneal center. So there is a difference in the architecture. So traditionally with our manual LRIs, we're going to be perpendicular to the corneal plane. So you can kind of see that in the sky blue, where it's perpendicular. And that's in contrast to being perpendicular to the coronal plane, and that's beveled incisions. And why does that make a difference? Because it's less likely to be associated with regression of astigmatism. And later on, I'll have some slides about why. So are they accurate? So of course, it's funny because when I first started using femto many years ago, I wasn't even sure if the astigmatism part really worked with my patients afterwards. But now with the latest, the one that I'm using, the LensAir Alley, we really do see it. And we're going to get into that, our data at our practice actually, how we looked at these patients afterwards. So yes, there is a significant decrease in refractive astigmatism compared to before surgery and after surgery. So here we have 91% of patients achieved a refractive cylinder within half a diopter postoperatively. And this is Dr. Denise Visco data, and she's provided a tremendous amount of data to LensAR and worked very closely with them, and she has amazing outcomes. So it's been very helpful for all of the other cataract surgeons to learn from her data. So this is actually done by Joaquin DeRose, who is not only my partner, but also my husband. And so we work at the same practice. And this is all of our data from 3 of the surgeons. And so we actually looked at this at our own practice because we want to see how we could optimize our algorithm, our formulas for arcuate incisions. And this kind of shows you beforehand. So our mean our mean spherical equivalent residual astigmatism, you can see, is about half a diopter. But then we optimized it with the help of the LensAR folks, and we got it like really great. So 94.9% of patients had less than half a diopter of astigmatism remaining. So that was pretty impressive. And actually, we just recently, we're still in the process of analyzing the data, but these same patients, what we did is we brought them back a year later, and they're still looking great. So more data about that at a future date.